everyone. I think we'll get started again. So our next panel is one on donor considerations and crowding in. So I think a nice follow to the panel before. We will follow the same format. So I'll start by introducing our panelists and then ask them each a couple questions, and hopefully leave a good amount of time for questions from the room. So first we have Dr. Tore Godal, the Special Advisor to the Officer of the Prime Minister of Norway. Next to Tore, we have Jennifer Adams, Deputy Assistant Administrator from USAID. Then Gargi Ghosh, from Director of Development Policy and Finance for the Bill and Melinda Gates Foundation. And finally, Aaron Holfelder, Policy Director for Global Health from the One Campaign. Dr. Godal, if I can start with you. You helped manage the Norwegian Ebola response. Can you describe the process that you went through to determine how to contribute, both to make best use of the Norwegian funds, but also to meet the needs in West Africa?
Thank you very much. So, Norway has spent about $60 million. That is not similar to 1.9, but if you take it on a per capita basis, it's more than $10 per capita in Norway. So then it is more per capita than some other countries. What we did was we responded very early to the call from NGOs. So Doctors Without Borders and the Red Cross, they raised the issue in the spring, in April, May. And so we responded by then providing resources for them. The rationale being that they were then basically on the spot in the peripheral part of the countries where the problems were. And then later we provided support to WHO because of their key role in relation to surveillance and providing data. And we are continuously impressed by the increasing significance of the African Union and their then commitment to actually to supply health workers to the three countries, which was clearly a very big constraint. So that was the main channels through which then the resources were given, and then to UNMER. But there was one additional thing, and that was in the beginning of October. The situation was very, very serious. It was a doubling of number of cases per week. I don't know whether it was Martin, but certainly CDC gave projections that it could be several 100,000 cases by the beginning of 2015. It could spread to the neighboring countries. It could even become a global pandemic if the virus changed. So we thought we cannot put all our eggs in just try to control this epidemic, and that's why we decided to fund a vaccine trial. And we took the most risky vaccine because that was the strongest vaccine. That was the Canadian vaccine. And based on advice and collaboration with WHO, we decided to do it in the most difficult country, Guinea, because we assumed that that would also be the country where the epidemic would last longest. And that then led to pushing through the development phases, phase 1, 2, and 3, and in March this year, the trial started. It was an unconventional design because Doctors Without Borders and the Guinean government were not keen on having a randomized trial. So we actually did a ring-fence study, which turned out to be the best way because then it was so light-footed, you could say, that we could move with the epidemic as the epidemic changed from places to places in the country. And as you may know, and from the media, the trial analysis by now showed that there has been no case of Ebola among those that had been vaccinated. 3,500 people that had been vaccinated had no Ebola case 10 days after they had been vaccinated, actually 6 days, while there has been 16 cases in those that were then not vaccinated. And in order to be fair to all communities, the control group was vaccinated 3 weeks later. So every expert in the world, those that have been totally independent of the trial itself, have concluded that this is really a breakthrough, and that we now have an effective Ebola vaccine. So that was the way that we invested in the Ebola outbreak.
Great, thanks very much. Maybe changing gears a little bit to be a bit more forward-looking now. So through the discussions over the last day and a half, we've talked a lot about different financing tools that may be available, for different phases of a pandemic. But the perfect tool is useless if we can't fund it. Can you talk a bit about some of the constraints on how countries can contribute to the various tools?
Well, first of all, Norway as a country will be fully committed to finance, to engage in the finance of preventing outbreaks of this nature and pandemics. At the same time, we want to be as smart with our finance as possible, and in light of the new financing for development meeting, we will put increased emphasis on the domestic resources and the domestic finance and linking to domestic finance. We will, as we have been now recently, very increasingly demanding results for our investment. Doesn't mean that we need to follow the money, but we need to have results. So, as I mentioned yesterday, leveraging the balance sheet of Norway plus getting results will be critical. So we will have, our strategy will be that we see as a comparative advantage to actually to invest in R&D, and we think that the way Bill Gates developed the agenda on that at a meeting in March in Berlin at the request of Merkel is a very important way forward. Basically doing R&D for, let's say, the top 10 agents that can cause pandemics, and then both look for develop vaccines, drugs, and diagnostics in public-private partnership mode. The second that is very key investment for us is the global financing facility through the World Bank. That facility and our dollars are directly linked to IDA, and so far it has been about $4 to $5 from IDA as compared to our single dollar. It is then not linked to the Ministry of Health in the countries, but it is linked to the Ministry of Finance to be linked to domestic financing, and it is results-based. And we understand that finance ministers like it because you can incentivize or use results-based about 4 to 5% of the total investment in health, and you get that 20% efficiency gain through that. And this is results-based at the peripheral level, so that the health workers and the facilities are getting additional finance relating to what they deliver, both in terms of quantity and quality, and it has a demand side providing conditional cash transfers to the poorest women so that they can actually access the services. And this also now gives the opportunity, by having an independent mechanism, verification of data, which is essential, that the communities can now have a say in terms of what bonuses the health facilities get, because have the health workers been on the job when they should be? Have had a good attitude, and have they actually delivered on what they should do? So we think this is important in relation to what we discussed yesterday, the relationship between health facilities and the communities, and can build a better relationship. And if we want to, we can incentivize also the discovery of new agents. So let's say at the regional or district level, there could be incentives as part of this scheme if then in one district or region one actually discover a pathogen that then are laboratory confirmed. So we think this is, in order to change the behavior I talked about yesterday from more curative to preventive, you usually need incentives. Knowledge is not enough, you need incentives. And so I think the question of incentivizing this may be an important tool. So we see the Global Financing Facility as a very important vehicle. It has now a commitment of about 1 billion, and with the IDA it will be then 4 to 5 billion. And then we are actively pursuing what we discussed yesterday in terms of how one can then leverage also private capital into this through various schemes and make, for example, IBRD loans as soft as IDA. So I would say that is our main second investment. And then we are engaged in health security. We are having established bilateral collaboration between the Public Health Institute of Norway with certain institutions, including Ghana, where we will then through collaboration strengthen the public health institutes, and we know a number of others have similar partnerships. And of course the AU have decided they want to have a CDC type center in every country in Africa. So that will be an important also aspect. And finally, as I mentioned yesterday, we are the third biggest contributor to Gavi and Import to Global Fund, and we see that in order to actually to get the level of resources that's required to develop robust surveillance and response mechanisms in the countries, we need to put infectious diseases, pandemic outbreaks, and even antimicrobial resistance into a consolidated effort and a consolidated way of dealing with these challenges. Thank you.